Hello everyone. In this video, we are going to learn about the principles of radiographic interpretation. Radiographs are important tools in the diagnostic process. Each radiograph contains a lot of information about the health and the disease of the patient. If we are careful enough and follow a systematic approach, we'll be able to harvest all the information available on the radiograph. We'll reach a good differential diagnosis. This will help us prepare a better treatment plan and help our patients. So without much delay, let's proceed. Before we learn how to interpret a radiograph, we should understand the purpose of imaging, why and when we may acquire radiographs. Not all clinical situations require a radiographic examination. First, we should conduct a thorough clinical examination. In this examination, you'll obtain clinical history, look for signs and symptoms, and review any previous radiographs if available. If the patient has previous images at a different clinic, we should try to get those images, whether full mouth series, panoramic, or any other image like a CBCT. Now that almost all the radiographic examinations are digital, getting previous images may be much easier than before. Based on the clinical examinations, signs and symptoms, and previous images, you may want to order a full mouth set of radiographs. You may also realize that only 4 by-twin radiographs may be sufficient for the current clinical situation. Depending on the clinical situation, you may order a panoramic radiograph, as a full mouth series may not answer your clinical concern. For some clinical situations, a full mouth series or a panoramic radiograph may not be sufficient. You may want to get a cross-sectional imaging such as a CBCT scan, a CT scan, or an MRI. When we order a CBCT scan, we should image only the area of interest or clinical concern. This could be a small field of view section of one jaw, of either the mandible or the maxilla, or both the jaws, or a large field of view including the jaws, sinuses, and the orbits. There is no one size fits all. We must avoid all unnecessary images. If our concern is proximal caries of the posterior teeth, only 4 by-twin radiographs may be sufficient for making our expected diagnosis. In this situation, there is no reason that we should get a full mouth series of radiographs. For example, if we want to identify if the third molars are present, a panoramic radiograph is often sufficient. We should not order a CBCT scan to answer this clinical question. Remember that radiographic examination must benefit the patient either in treatment or in follow-up. We should never use radiography for the sole purpose of keeping a record or for making money. The same principle also applies to all clinical procedures. Do not do a clinical procedure just to make money. Once we have acquired our images, let's learn the principles of how to read a radiograph. First, find a quiet corner without any distraction to read your radiographs. If you are going to practice in Minnesota, probably you will have a bright, beautiful dental office facing White Bear Lake or Lake Minnetonka, or one of the 10,000 lakes that we have. Your clinic will have big, bright windows. That is excellent. However, such bright rooms are a disaster for reading radiographs. You will miss important subtle radiographic findings. You may also miss caries, root fractures, and many other important diagnostic clues. So turn the lights down. Make the room as dark as possible. Suddenly, you will start to see better. Keep your workspace clean. No extra lights, no clutter. I'll remove that flower pot. Anyway, the flower was not very happy in the dark reading room. Okay, I'll keep that coffee only if it is in my home office. Don't bring coffee or any liquid to our clinic reading rooms. Liquid and electronics are not real friends. For better interpretation, keep the monitor clean and use some darker shades of the desktop background. The extra white lights from the screen will actually make your vision weaker. There you go. Now it's better. If you come to our office, don't assume that we are animals of darkness. We are just trying to read the radiographs better. It's equally important that we also know our software. Spend some time to learn all the tools available in your software. The imaging software is powerful. That does not mean that the software is free from flaws and limitations. Understanding the limitations of the software will also help us appreciate the information that we are getting or not getting from the image. Some processing of the images may be needed. I want to add a word of caution not to overprocess the image. While you may gain some diagnostic information by this extra processing, at the same time, you may also lose some other critical diagnostic information. With that foundation, let us learn how to systematically read a full mouth set of radiographs. I start looking at the crown of the tooth, then the root, then the periodontal ligament spaces, the surrounding trabecular bones, and any other structures adjacent to that tooth. If I have a full mouth series, I start with tooth number 1 and then I review one tooth at a time to reach number 16. Then I'll go to the mandible and proceed from tooth 17 all the way to number 32. If you are watching this YouTube video from another country, please follow the international tooth numbering system. For each tooth, again, I'm reviewing the crown, the root, pedial spaces, and surrounding trabecular bones. Using this full mouth series as an example, if I'm looking at tooth 2, I'll use multiple images to review this particular tooth. As I mentioned, I'll start from tooth 1 and continue with one tooth at a time all the way to 16, then mandibular left third molar region, continuing all the way to number 32. This is my protocol for reading a full mouth series. It is not necessary that you follow my protocol. You can have your own protocol for reading a full mouth series. You may start from the maxillary central incisor, then go to the mandibular central incisors, then maxillary lateral incisors, then mandibular lateral incisors, then the canines and the premolars and the molars. If that is your protocol, it's perfectly fine. The only requirement is that you will follow your protocol all the time. You should not jump from the canine and then to the mandibular central, then to the premolar here, then to the molar on the left side. Even if there are interesting findings in some areas, follow the protocol. Follow the same principle of reading a panoramic radiograph or even a CBCT scan. If we follow the same protocol, it will protect us from missing some important diagnostic information. Look at the crowns, the roots, the periodontal spaces, bones, and adjacent structures. I'll still follow the same protocol of tooth number 1 to number 16 and then 17 to 32. For panoramic radiographs, also spend time reading the temporomandibular joints, the orbits, the sinuses, and the vertebrae. On this image, I have an interesting finding in the mandibular anterior region. Instead of jumping directly into this area, I'll follow the systematic protocol. This is one technique to ensure that we systematically read the full panoramic radiograph. Divide the radiograph into 9 segments. The first segment is the dentition. So I'll read from number 1 to 16, 17 to 32. After that, read the ramus and the cervical vertebrae from both sides. Then read the temporomandibular joints. Then read the orbits and the sinuses and the nasal fossa. Read the inferior border of the mandible. And then read the neck regions bilaterally. After reading the complete image, then I'll come back to this interesting lesion and spend some extra time to make the diagnosis of this lesion. Let's do an exercise of reading an image. No, not this panoramic. Let me bring a colorful image. This one looks good for our exercise. This image is obviously not a radiograph. All the radiographs are pictures. This is also a picture. So let's see if we can harvest some information from this picture. A few years ago, I took this picture. we can see the front of a building, probably a tourist area. I think it is a tourist area because I see several people taking pictures. Looking at the sunlight and the shadow, we can assume that this picture was taken in the afternoon. Because a few people are wearing shorts and some have light jackets, we can assume that the temperature is quite comfortable. Not too hot, not too cold. Yes, it was October. No, not a Minnesota October. We see that there are two Rolls-Royce cars. Looking at the license plate, we see that the car is from Dubai. The other car also has some Arabic writing, probably also from Dubai. On one side, there is a Mercedes. On the other side, there is a Bentley. So do you think that I took this picture in Dubai? If we read this picture a little carefully, little more attention and magnify to the board, we see the doors are to the Grand Casino Monte Carlo in Monaco. Interestingly, these two cars have consecutive license plate numbers. So someone has enough money to buy two Rolls-Royce at the same time. I cannot even buy two Honda Civics at the same time. This person has enough wealth to buy two Rolls-Royce and also spend time in the casino. Surely the tourists, like me, were not here for the gambling. They just came here to see the cars and the nice architecture. So, what did we do? By analyzing this image, we figured out the time of the day, the temperature of the day, the location of this building, and the type of people who visit such a place. Similarly, if we analyze any picture, we can harvest a lot of information. If you visit Monaco, you'll also see other expensive cars from different locations. But the Prince of Monaco likes to drive Lexus. Enough of that. Coming back to radiology, similar to what we did with the casino picture, a step-by-step systematic approach will provide us with the best diagnostic information. The information is there and we have to harvest it. The step-by-step analysis is important because a lesion on one patient may appear slightly different from the same disease on a different patient. What you have seen as an example on a textbook may not be the same presentation in your clinic. Even if the lesion on our case have a different appearance, we have to identify the radiographic features and then come to a radiographic diagnosis. Other than the step-by-step image analysis, there is another way of arriving at a diagnosis. This is called ANT-MINI. You may use picture matching or ANT-MINI for common conditions only. The term ANT-MINI was coined by Dr. Neuhauser from Boston and then made popular by Dr. Felsen from Cincinnati. ANT-MINI is a condition that does not require any description to arrive at a diagnosis. You have seen these common conditions earlier and you can quickly make a diagnosis. ANT-MINI is your aunt whom you know very well. If you see her in a group of people, you have no difficulty in recognizing her. Examples of ANT-MINI conditions in dentistry can be carious lesions or horizontal alveolar bone loss. You have seen such diseases so many times that you do not have to describe it. Other conditions such as cysts, benign tumors, malignancy, dysplasia, and many other diseases require step-by-step analysis. ANT-MINI is only for well-known common conditions. Here is a picture of a very well-known person. Even though this is a silhouette and you do not see the color of the hair and the color of the tie, you still know that this is President Trump. Similarly, it's very easy to identify President Obama, even by looking from the back of his head. How did we so quickly recognize them? Because we have seen their pictures every day for so many years. Such would be the examples of ANT-MINI. You know them very well and you can recognize them very quickly. Let's see what happens when we encounter a lesion and we try to use ANT-MINI protocol, which is the non-analytical approach. If we have a disease, and it is a known condition, we can easily reach a diagnosis. No problem is here. However, if we have a disease that is a known condition but unusual features, then by using AND-Mini protocol, we cannot come to a diagnosis. We end up with confusion. The worst situation is if we have a disease and it is an unknown condition. You did not learn this in the classroom. It's also not written in the textbook or other literature. The end result is the same. We have no diagnosis. Remember that we do not have enough time to teach you thousands of diseases. So what happens if we use analytical step-by-step method? Again, if we have a disease and it is a known condition, we can still arrive at a diagnosis very easily. If it is a known condition with unusual features, we can still arrive at a diagnosis or build a list of good differential diagnoses. If we have an unknown condition, at least we can classify the disease by looking at the features. Once the classification is done, we can do a literature search to see if someone has already reported such a rare condition. If so, then we have a name. If the literature search fails to identify such a lesion, then you can give a name to this newly identified condition. For step-by-step analysis, we have to describe the lesion. Before we try to describe the lesion, it's essential that we know the normal anatomy and the variations of normal. Without knowing the normal, we cannot describe the abnormal. The necessity of the knowledge of anatomy can never be overemphasized. First, we have to describe the location of the lesion or lesions. How many lesions? Is it one or multiple? Where is the lesion? Is it localized or generalized? Is it related to the crown? If it is related to the crown, it cannot be a radicular cyst. If it is related to the root, then it cannot be a dentigerous cyst. Is this finding in one arch or both the dental arches? Is this lesion inside the bone or outside? Is the lesion superior or inferior to the mandibular canal? Once you have described the location and the number of the lesions, let's go to the second radiographic feature. You will describe the density of the lesion. The lesion may be radiolucent, which is dark on a radiograph. This may be radiopaque in different shades of white, or it can be mixed, both radiopaque and radiolucent. We should describe the size of the lesion. The best way is to describe in millimeters or in inches. Please describe in all three orientations: cranial, caudal, mesial distal, and buccal lingual. Because panoramic radiographs are always magnified and somewhat distorted, just provide an approximate size on a panoramic radiograph, such as the lesion is as big as the crown of a molar, or the lesion extends from the area of the second molar to the area of the first premolar and extends from the crest to the inferior alveolar canal. Do not use the terms such as large, small, or huge. These descriptive words may mean different things to different people. Some lesions, such as a cyst, can be circular or oval. Some lesions, such as a traumatic bone cyst, may scallop between the roots. Ameloblastoma can be multilocular. The shape of the lesion is also a critical clue to the diagnosis. The border of the lesion is another critical clue to the diagnosis. Is the lesion well defined or poorly defined? Is the margin smooth or irregular? Malignancy and infection often have irregular margins. Is the lesion well corticated? Frequently, a cyst or a benign tumor is well corticated. Is the margin sclerosed? Sclerosis is frequently a sign of remodeling due to infection. Is there a radiolucent band around the lesion? Or is the lesion blending to the neighboring structures? The more you describe, the closer you will be to the diagnosis. Some lesions may have internal contents or internal entities. If you see internal entities, describe this. Are there internal calcifications? Is there a tooth inside the lesion? Finally, and very important, to describe the effects of the lesion on the adjacent structures. Is the lesion expanding the cortical plates? Or is the lesion perforating the cortical plates or resorbing the roots? Are the neighboring teeth displaced? How about the sinus floor? What is the status of the inferior alveolar canal? Is it displaced or compressed? The wall may be eroded. The effects on the adjacent structures are probably the most important clue to the diagnosis of a rare lesion. At the same time, also describe if some adjacent structures are generating the lesion, such as pulpal exposure leading to a periapical lesion. In review, these are the 7 radiographic features to describe: location, density, size, shape, border, internal entity or internal content, and effects on adjacent structures. You do not have to describe all these features in the order that I have presented. You may mix them up. Let's mix them up to remember them better. I think we can remember them better now. Yes. I feel blessed that I can remember all the 7 radiographic features to describe. Let's use this radiograph to understand how to write a radiographic report. We'll be writing about this particular lesion. As mentioned earlier, we'll start from tooth number 1, go to 16, and then 17 to the 32 area. But for saving time today, we're just trying to write a report on this particular lesion. So this is what I wrote. A well-defined corticated oval radiolucent defect is superimposed over the apices of carious mandibular left first molar. This lesion extends from the area of the distal root of the mandibular left second molar to the mesial root of the mandibular left first molar. Superiorly, the lesion is a few millimeters from the alveolar crest. Inferiorly, this lesion has displaced the inferior alveolar canal. Compared to the right side, the roots of the second molar are distally displaced. So let's see, what did we describe? The word A means a single radiolucency, which means that it's not generalized. We have well-defined corticated that describes the border of the lesion. The oval describes the shape of the lesion. Typically, a cyst is circular or oval. Some of the benign tumors may also be circular or oval. The word radiolucent describes the density of the lesion. You can see that within a few words, we have described the border, the shape, and density. With the word radiolucent, we are thinking of a lesion that has fluid or soft tissues. Now we are trying to describe the location of the lesion. It is superimposed over the apices of the carious mandibular left first molar. Create the habit of using the word superimposed. The word superimposed means that the lesion may be buccal to the roots, lingual to the roots, or around the roots. We do not yet know the relationship of this lesion with the roots. A panoramic radiograph is a two-dimensional image. Therefore, we have to mentally think if the lesion is actually associated with the roots. Again, make a habit of using the word superimposed. We also use the word carious in the sentence. This word is telling us the cause of the lesion. We are describing things that are happening adjacent to the lesion. Now we are already making a radiographic diagnosis of a radicular cyst associated with a pulp-exposed mandibular left first molar. I could have used a few words in my note describing the extent of the carious lesion. Here I am describing the size of the lesion. I'll not use the term as a large lesion or a small lesion. Such descriptive terms are not precise enough. A panoramic radiograph is often magnified and distorted. I'm not providing the size in millimeters or inches. If I see this lesion on a CT or a CBCT scan, I'll provide the size in millimeters. I have intentionally remained non-precise by using a word a few millimeters from the alveolar crest. A panoramic radiograph is not reliable for measurement. I'm still describing the size of the lesion. I'm telling you that the inferior border of the lesion is at the level of the inferior alveolar canal. In the same sentence, I have also described the effect of the lesion. This lesion has displaced the inferior alveolar canal. I'll continue to describe the effect of the lesion on the neighboring structures. This lesion has displaced the roots of the second molar. With this description, I'm thinking of an expansile lesion, a lesion that may have hydraulic pressure. Combining all this description, I can arrive at a radiographic diagnosis of a radicular cyst associated with the carious and pulp-exposed mandibular left first molar. There you go, an example of a radiographic note using the BLAST format of description. Border, location, internal content, size, shape, effects, and density. In many lesions, you may not be able to describe the internal content. In some lesions, internal content such as calcification may be the critical clue in arriving at a diagnosis. The diagnosis of any disease is not very difficult. You need a little bit of knowledge, an ounce of knowledge, a little bit of intelligence, but what you really need is a lot of thoroughness. So the step-by-step analysis is the best way to arrive at a diagnosis. Some textbooks will use terms that describe characteristic findings of a lesion. You may see terms that describe a lesion such as sunray appearance, cotton wool, ground glass, onion skin, driven snow, or crew-cut appearance. These are descriptions of the classic radiographic features. A disease condition may not always show the characteristic features. I suggest that you do not use these terms. Rather, you should describe the radiographic features of a lesion. This is more likely to help you arrive at a diagnosis instead of depending on the classic terminologies. If you are from Minnesota, you must like fishing. We have 10,000 lakes. Most Minnesotans see fishes everywhere, even on a radiograph. No, this is not a fish. This is the airway because the tongue was not in contact with the hard palate. If you are from Texas, you do not see a fish. You see something else. This radiograph was shared with me by my friend Dr. Ken Abramovich. What you see here is a Texas longhorn, just like this. This young man is not swallowing the sun, but the photograph is wonderful. Not sure about the other photographer. He is on the other side. Most radiographs, like this picture, are two-dimensional images. It may be difficult to know if a lesion is buccal or lingual or inside the bone. I suggest that you continue to use the term superimposed to describe a lesion. This man may be holding up the Leaning Tower. As you know, he is not even close to the tower. But a two-dimensional image does not really help us with the distance between this man and the tower. My friend could not take a good picture of me. My hand is not really at the top of the pyramid. Ha ha, funny. One bird or two. Actually, these are dry leaves. Do not make a quick Aunt Minnie diagnosis. Maybe she's floating in the air. Or is there a shadow of a flag? A few years ago, we were in Tanzania. In Serengeti, I was trying to take the picture of this elephant as it came closer to the giraffe. I was looking through my telephoto lens and waiting for these beautiful creatures to come closer to give me a once-in-a-lifetime photograph. As I was waiting and moved my eyes away from the viewfinder, I see this guy is staring at me. And this is our vehicle. So please remember to review the full picture or the full radiograph. There are often multiple lesions on a radiograph. A patient may have several diseases at the same time. As a clinician, it's critical that we thoroughly review the image to identify all the diseases that may be there. Thank you very much. Please come back again for another interpretation video.